Congratulations. So welcome. We are delighted that you can join us for this.
Well, thank you, Ray. That's a very kind introduction. Bit of a surprise. You shouldn't have told us how we started the program because there might be some repercussions here now. But thank you for joining the session today. I was hoping not to talk about the reason why this grand round was rescheduled. I was actually planning on giving this grand round, which is very overdue in 2025. But thanks to Dr. Colette Inaba and Dr. Deb Marquardt, we were able to reschedule. So hope it is somewhat enjoyable without caffeine for those in this room. Maybe it'll be a very short presentation. Thank you. So these are my disclosures. I served as a consultant for the robotic CUSA development, received some stipend for travel, and served as an advisory board member for the IMbrave 050 trial. It's the adjuvant atezo-bev trial for HCC resected and or ablated. And while I have admittedly drunken the Kool-Aid, I do not receive any funds from Intuitive. So any slides that are related to the technology are mainly to introduce the technology to you, not necessarily to promote it. This is a quote from this novel where the protagonist, Lazarus Long, emphasizes the importance of historical awareness, without which there can be no prosperity or survival of a society. So just wanted to take a little bit of time and go back and talk about history. Okay, so that last slide is missing, but it just talks about the term robot. It originates from a play in 1920 by a Czech writer and playwright, Karen Čapek. And the term in Czech means, or robota means sort of indentured labor or drudgery. And it was a novel to indicate how the society was changing, but these robots were organoid AI figures and were not mechanical necessarily. The term robotic for our purposes today does not indicate any sentient being or artificial intelligence, but it's mainly manipulation of surgical tools that are guided by either an algorithm or program. And at least currently, although I suspect that not too long from now, there will be automation of this technology. The first robotic surgical procedure was performed in April of 1985 in Long Beach, California, by a neurosurgeon, Ronald Young. And this person listed here, Yik-Sun Kuo, who's a very illustrious radiologist slash neurosurgeon slash engineer who put together two technologies that were present at the time, the CT scanner and the Puma 560, which was developed by Victor Scheinman. It was a six-armed industrial robot that was able to do automated tasks using a protocol. And ingeniously, Dr. Kuo was able to put the two together to perform a biopsy on a 52-year-old with a brain tumor. And the level of delicacy was that he was able to repeatedly, although the initial preclinical trials were on watermelons, on the human was able to demonstrate that accuracy or precision up to 0.005 inches, or in metrics, 0.0127 millimeters. So quite extraordinary at the time. In 1992, UC Davis orthopedic surgeon William Barger and veterinarian Hap Paul collaborated to build this Robodoc. It's a device that would bore holes into the femur of patients undergoing hip arthroplasty. At the time, the surgeons had to do all this by hand, and the holes didn't quite match the prosthetics. So then you would have to pour glue into the hole, and over time, with wear and tear, the patients had a tough time with replacements. And while it may have been a good financial plan, I'm just kidding, but it was not very good for the patients. So they developed this drilling device. It used CAD and CAM technology, so computer-assisted design and computer-assisted manufacturing, for the first time to do this. And they have performed now over 28,000 orthopedic cases, and this Robodoc is now in the Smithsonian American History Museum. There was a lot of interest by NASA and the military, specifically the Army, for telepresence and being able to perform complex tasks in distant sites, like in space or on the battlefield. And along with them, Caltech and Stanford Research Institute had a lot of expertise in 3D vision, haptic feedback, and head-mounted displays. So this type of technology was all brought together, and a device called ASOP. It's automated endoscopic. Sorry, I'm having a hard time with all of these acronyms, but it's automated endoscopic system for optimized positioning. So it's basically a robot arm that would hold an endoscope in place so that the surgeon can do a laparoscopic procedure. It was by 1996, it was voice controlled. So you can talk to it and it would tell you, look over here, look over there. Didn't see it in motion, but look for videos, couldn't find it. But what was clear that was when a trial was performed compared to an expert bedside assistant, I presume that this was greater than R1 level, but our R1s are quite good. And you can see that on all metrics, the human assistant performed better than the robot. So the conclusion of this trial was that while it was feasible, so 94% of the time laparoscopic cholecystectomy and hernia repair was feasible with this device, the patient would have to sacrifice some comfort level with the potential of reducing staff for financial gain. That was the take-home message. So this technology was adopted into Zeus, and this is not an acronym. They named this machine Zeus, and this is a company called Computer Motion that was co-founded by Yulin Wang. And he thought that you could have a system where you have 3 arms coming out of the operating room table, one for the camera that's controlled by this ASOP system, and 2 controlled arms. And you can see this surgeon wearing a headset through which he voice commands the endoscope. And he's also it's not well seen here, he's also wearing polarized goggles so that he can see in 3D for the first time. And this prompted what's called telesurgery for the first time. So where a surgeon is not necessarily at the bedside performing the procedure, and they were able to perform simple tasks, including laparoscopic cholecystectomy. And with this device, approximately 25 laparoscopic cholecystectomies were performed. And once the learning curve had been overcome, there was a transatlantic procedure called the Lindbergh operation that was performed between New York City and Strasbourg, France. And this was pictured here is Jacques Marcoux, I can't pronounce it, but and Michel Gagné and Francois Mutter were the three surgeons that took turns doing this procedure. There was a bit of a delay, so 155 milliseconds going to France and then coming back for the signal so that the surgeon could respond. So there was a bit of a delay, but certainly it showed the potential use of this telesurgery. And this is Fred Moll, who is a co-founder of Intuitive Surgical. He founded this company in 1995 and then eventually took over Computer Motion in 2003. But they also took the technology from Stanford's Research Institute and developed a three-armed machine called Mona, which was the predecessor of Da Vinci, which is used here. And now there are 5 or 6 different iterations of the machine. So that was the beginning of robotics surgery, and I'm sure there's lots of gaps, and there are different accounts of this same story, I'm sure. But the beginnings here at UW, the first cases were performed, 3 cases were performed in 2003. Not just these surgeons, but I'm well aware that there are many other surgeons, including Dr. Oshalager, Dr. Wright, who are involved in the development of robotics here. There are also gynecologic surgeons and urologic surgeons who performed the first in the Pacific Northwest in Washington State, single console and dual console hysterectomy and prostatectomies. And we also had a hand in our department. And the late Eddie Mendez really pioneered the field of transoral robotic surgery. So this is what our program looks like today. Since 2003 at Montlake campus and 2007 at Northwest campus, we've done combined, I don't know, about 22,000 cases and counting. Year by year from 2012, these are the figures, and I would say that the main reason that we're not exponentially rising is because of the limited access that we have, but we'll go into that a little bit later. There are 4 dual XI consoles at Montlake, 1 single console SP, and 1 dual console and 1 single console XI at Northwest Hospital. I just wanted to take a brief moment. This is not a talk about why we should do robotics, or I'm trying to brainwash you into doing robotics or convert you to robotics. There's just one slide that talks about that, but this paper just recently got accepted at the Journal of American College of Surgeons, so congratulations, Dr. Sham. But it's a 6-institution multinational study looking at outpatient liver resection. This is just a history of the development of liver resection for open cases, and it took over a century with, as Dr. Bloomgard puts it there, blood, sweat, and tears, not only of patients, but also of surgeons and innovators to develop this prowess, surgical prowess, I would say. The history for robotics surgery is rather short comparatively, just over 20 years after the Da Vinci system was FDA approved in 2000. The first robotic liver resection was performed in 2003. But since then, you can see an exponential rise in the number of publications that are being published year after year about robotic liver resection. It's not about robotic surgery, but robotic hepatectomy. And there have been 2 international expert consensus guideline meetings on this topic. This is the latest of which was in August of last year. And sorry for the slide, but you can see that all of the indications that are being performed for both open and laparoscopic can and be safely performed using the robotic approach, both for minor and major hepatectomies. But maybe of interest to the, or not of interest, but they're well aware, Dr. Sturtevant and Dr. Hirose, for live donor hepatectomies as well. The way that I see robotic liver resection really being utilized effectively are in these three arenas. Those where we call incision dominant procedures, where overcoming the incisional pain is really the big component of the recovery of the patient in minor hepatectomies. And as you'll see in this data, these are the majority of patients that we sent home the same day, if not the next day. But also parenchymal sparing liver resections, which are much more complicated. You can't bill for them as much, but that's the right thing to do for the patient because these patients will invariably have recurrences, and so we'll come back for additional treatment. And finally, applying robotic technology so that we can do more safe and more commonly major hepatectomy. So all surgical presentations have to have a video, so this is one of the videos. But it shows a middle hepatic vein in a cirrhotic patient that's being repaired. And I can tell you I cannot do this laparoscopically. And so this patient was able to have this procedure and leave the following day. So it just gives you an idea as to what the robotic platform is able to provide for those with experience in laparoscopic surgery. Compared to open hepatectomy, it's the usual, as you would expect for any minimally invasive procedure. And for laparoscopic procedures, especially in the realm of liver resection, there are some advantages that could be had, as we had discussed. Of the 4,000 plus liver resections that were performed in total between the 6 institutions, 27% were robotic. I would say that that number is higher for our institution, but some other institutions rather conservative or maybe more prudent or wise. The robotic hepatectomy outpatient procedures were performed surprisingly in 25%. A quarter of these patients left home by CMS definition, no more than 2 midnight stays. This is the demographic of this patient population. You can see the majority of these patients underwent surgery for malignant disease, and the majority of them had comorbidities that had to be co-managed by our team. You can see that the majority of patients did have 1 or 2 out of the 8 segments resected, so fairly minor resections. But what's notable is that the more difficult locations, the superior segments like 2, 4A, 7, 8, and posterior segments, resections was close to over 40%, which was quite surprising. And the EVL, which is a horrible metric, but still relatively low, and no transfusions, which I think is more correct to look at. There were no transfusions for this group. The positive margin rate was higher. I would say somewhat unexpected and also unacceptably, but I think this may change over time with experience. You can see that the majority of patients stayed overnight, and complication mortality and readmission rates were all very acceptable compared to laparoscopic open procedures and those that stayed longer. The limitations, of course, this is a retrospective observational review. There's complete variation in terms of patient selection. No one knows who is chosen for the other institutions, how we even choose between one patient to another. And ERAS protocols are quite variable and certainly no better than Taylor Swift's tour. So this is the fleet that we have currently in our system. And I'm not sure how long Valley will be with us, but I've included it just for completeness. At Montlake, as I told you, we have 4 dual console XI systems. They're rather aged at this point. For a robot system, when it goes to above 4 years, they're considered aging, which is a sensitive topic for me. But and at Northwest, there's 1 dual console and 1 single console, which is a sore point that I know. Yes, I see Dr. Peterson nodding her head. As a very sore point that we have been trying to overturn over several years now, because the dual console, as you'll see, is quite important for resident training. This is how you get credentialed at UW. There are three paths. Either if you were like me, had no experience previously, you would come in and you would do all the online training, go to Sunnyvale with Ray. I don't have the same recollection as you do, but get the formal training, come back, and then you have to have a mentor. And my mentor was Andy Wright. And while he did not do liver resections or pancreas resections, he was an excellent teacher for robotics. And he sat through just painstakingly long liver resections, and he proctored my first three cases. And that's what's required to build a program, is a mentorship and collaboration. The second path is hopefully all of the residents and fellows that are coming out of this program soon. We don't have a high percentage at this time, but really everyone should be trained and certified by the time that they leave. And there's a path towards that. And I think if you're not, unless you're avoiding robotic cases, which I know sometimes, unfortunately you have to make a decision, but you will get certified. And Dr. Peterson, Dr. Kandawal, and Dr. Citrullo will make sure that the educational component will thrive. And then finally, if you're transferring from another institution, you would have to present your robotic log. And if you haven't done robotic cases for over a year, then you would need to demonstrate some form of quote unquote remediation and or proctoring in order to be safe with your launch again. This is how the surgeon is expected to go through their timeline. Look at this credentialing timeline. You can see the orange out dates are already passed because time doesn't wait for anybody. But the next time that your chance to submit your papers and be reviewed are listed, and that's what prompts you to schedule your training, your cases, and so forth. And I can tell you there are a lot of questions about this, and many who want to bend the rules, but it is unfortunately necessary. It is the only platform, really, the only technological platform where training is required. But I do think that the training has really pushed the field forward, not inhibited its growth. But credentialing, I think, definitely needs some work. I'm sure Dr. Oschlager is well aware of this pain point, but the way that credentialing is done is there's a PDF, and while electronic, so it's not Pony Express, it is sent back and forth between the division chief and the chair of the department. And then because robotics surgery is a special privilege, they wait till the very, very end. And the day before the papers are due, they ask for signature. Not all the time. And I'm not trying to make this us versus them, but that is unfortunately the current system. And that system will need to change. And we have a discussion about this in June. But as you can see, there are a couple notable things that need to be changed. First, robotics should be across all campuses, privileged, that is. Once you are proficient at the technology, it really shouldn't matter whether you're doing the operation at Montlake or Northwest or Seattle Children's or VA or at Valley. I mean, you should be credentialed. We currently have it this way because we are separate systems, and there are some logistical barriers and some advantages of having the system this way. But I think as a health system, we need to go towards standardization. And second, this should be electronic, like truly electronic, not PDFs going back and forth, but an electronic system that you can log into and sign off after reviewing all of the cases that are present, so that you don't have to yet again send an email asking whether this surgeon has done cases over the last year. So always room for improvement, as I tell my residents, but that's always good for development. Switching over to training. This is a relatively outdated curriculum that we have, and it's sorely in need for revamping, and I'm sure Dr. Peterson will take care of this. Sorry, Dr. Citrullo will take care of this, but I have to give kudos to Caitlin Lee and also to Rebecca for allowing her and also being actively involved with all of these discussions for the robotic training, and Sydney Kaiser for helping out. This resource is very hard to come by. To bring a system over for 2 weeks at a time, twice a year, It required a lot of negotiation. This is a resource that I never had. I wish I had. And it allows training of all of the interns, no matter what service you're on. And I appreciate all the program directors. I see Dr. Singh here, that have allowed their residents to participate so that everyone is safe. It's a mandate for the medical system as a whole that any resident that touches a patient that's undergoing robotic surgery have the appropriate training, especially at the bedside, but even at the console. So that training takes place in July when the patient residents come in, and then it's repeated again in February, and it goes on and on. There are additional specific junior/advanced level training that's taking place now, and we're excited about that. We just had one not too long ago at Swedish Science Foundation, and there's another one that's happening in October. And for those that, it's called advanced training, but I would say that it really should be just standard or even mandatory training, quite frankly. If you go through the residency, you should be certified. But the requirements currently for certification as a resident or fellow is based on the number of cases that you perform or participate in. So 10 bedside assists and 20 console cases. Now, we all know that volume-based training is not only not equitable, but also not very meaningful. So that will change in the future. And the technology that will help us do that is this. This is the My Intuitive app. It's illustrating, let's see, 3 cases that were done recently. You can see on the left panel, it's a recent liver resection that Dr. Benny and I performed. You can see that once she is logged in, we can see who has control of which instrument at any given time. She participated a reasonable amount of this case, although it wasn't like a super challenging case, but I mean, she did really well. And then the 2 pancreatic duodenectomies, they were trying to hide, but I found out who they are. They're Drs. McCarg and Dr. Little. They also did very well in these procedures, and Andy does this really well. And I think Nick does this really well as well. But from what I've heard, you have very specific tasks that the residents come in knowing that they're expected to do. They prepare for that task by doing the simulation training. And then you are given a specific amount of time to complete that task during the procedure. Liver resection, a little bit more challenging to do. Pancreatic duodenectomies, you can do the gastric jejunostomy, the cholecystectomy, obviously, for the juniors, and then sometimes the hepatico-J and pancreatico-J. So you can look at the cadence of who has control, and you can see over on the right, pancreatico-duodenectomies, you can see that I can tell that they had a part in the hepatico-jejunostomy. This is not to blame later, but they did a part in the hepatico-jejunostomy, a little bit of dabbling with the pancreatico-J, and then the majority of or at least half of the gastrojejunostomy, and that's what's illustrated there. Once certification is completed, a letter and a certificate is rendered to the trainee as they go off to their next adventure. This doesn't work here, but there have been numerous simulation Olympics that the residents have participated in. And we've tried to entice them with these stupid videos and also cash and bragging rights and so forth, just to, but our surgical residents by nature, because surgeons by nature are very competitive, but in a healthy way. And I think using this to our advantage, will be, maybe it is working. But you can see Dr. Cham was a champion in 2016. Dr. Lois is on here, and yeah, lots of people, but lots of memories. And then the new group, geez. And our training program is definitely top gun. This is creme de la creme. The training simulator is available 24/7. It is in a difficult location to access currently. We are still working on that. But that simulator and dedicated surgeon console was difficult to come by. No one gave it out for free. We participated in a program called the Catalyst Program. It required the program director at the time, Karen Horvath, and some of the C-suite folks to join in an outing. And we visited Cedars-Sinai Hospital. The reason that I chose Cedars-Sinai is because a few years prior to the visit in 2019, they were behind us. They had just one robot. They were doing, just urologic cases. And they frog leaped over us like nobody's business. And I wanted to see what they were doing differently to learn from them. So we went and visited their site, learned quite a bit. Also saw that we were doing things, some things a lot better than they were. And that's what led to getting the simulator and surgeon console. It took 9 months of waiting and badgering and offering my firstborn and things like that. That was probably not that helpful. But this is the simulator. It's a backpack that sits on the surgeon console. It's connected by Ethernet. All of the modules that you complete get uploaded to the web. It now shows up on your phone. We can track it as system administrators, so we know who's doing what. And you can see that we also can keep track as a system how many modules were completed over quarter. And the 2 units that are listed here, the 0045 unit is in the OR. It hops around between ORs 1 and 4 to whichever surgeon wants to use it before their cases. Tom Lenve, who's a surgeon primarily at Children's, I don't know if he's still here, but he had a trial funded by the DoD that was showing that doing these 15-minute exercises prior to procedure significantly improves surgeon performance. So the goal obviously is to have one of these simulators in every room and ready access, but that is just not reality. Each of these units costs $100,000, and the subscription fee to update the modules costs $20,000 a year. And obviously, if these are located within the OR, then the residents don't have access to them because you have to wait for the cases to be done. So unless you're coming in super early, or you wait until all the cases are done, or you come in on the weekends, and even on the weekends, we are now utilizing the robots, and thanks to Dr. Oschlager's support, we have a dedicated PA, Sydney Cohen, who works on many of the Saturdays, who supports these cases. So it's very difficult to access to get on the simulator. So this SU0992 unit was stationed in WISH when the WISH unit was down in the surgical pavilion. And while cumbersome, the residents still made an effort. And then, as you can see, the number of modules that were completed, and if you take Q4 of 2020, Q1 of 2023, these likely will match the simulation Olympics that we were having, but still, it takes effort to take time away from your clinical duties, all the charting that you have to do, and resuscitating patients and taking care of my patients that have leaked or are leaking, to go over and take care of business and beat your competitors. It takes effort. And as you can see in Q3 of 2023, that number plummets. And this coincides with the unit moving from WISH to, it is still WISH, but it's over to the T wing. So now it is in T 671, and it will be there until, I think, late May. It's coming up soon, but it'll move down to the 2nd floor. It's a little bit better. I highlighted that you need to badge in, and this badging process takes, the university charges $10 per individual, which I think is ridiculous. But anyways, the WISH folks are willing to chip in for that. Lots of problems. Anyways, I'm showing you this map just to encourage you to still use the unit that's going to be moved to the T-wing on the second floor. And I'm in talks with Carla Brannon to try to move it back to the surgical pavilion. And the rationale for that is this unit is not solely for residents. The surgeons also want to use it. So to provide additional access to them, we will try to move it to the surgical pavilion if possible. But you can see the map of the hospital there. You can see Annie Yang is resuscitating one of the patients here. One of my patients, I think, or me. Don't resuscitate me, please. And you can see the two areas where the simulator used to be and is currently. And I heard a lot of complaints. This is too far away. Have you even been there? So on and so forth. So I recorded how long it takes from each site and measured the time. And this is sped up so that you don't have to go through this whole 3-minute, 18-second video. But when you compare the two sites, they're actually not that far away. They're separated by, occasionally there are people trying to get in your way, so you have to knock them out. But there's a 4-second differential between the two sites. And while I understand that the WISH Center, where it used to be in the surgical pavilion, is closer to the patient care area, so I know that there are definitely advantages, but just to let you know that it's not as far as you think. Next, switching gears to Center of Excellence. There's no society-based accreditation for robotic surgery for either surgeons or for institutions. So we sought out whether we could become a Center of Excellence, and lo and behold, the Surgical Review Corporation, which is a nonprofit organization, has the only, at least as of now, Center of Excellence in robotic surgery. I quickly looked up whether it could be the first, because the first you can never take away. And we recognize that we would not be the first in the nation, of course, but we would be the first west of the Mississippi. So we spoke with the powers that be, with C-suite and so forth. It requires an audit. So there's a visit similar to JCO, but not that grand of scale. Where it's a 2-day visit, site visit, where the administrator of the accreditation will come by. You actually have to present cases and charts that are anonymized. They go through all the complications. We go through all the complications, especially for my cases. At least one of the surgeons has to have a lifetime case number of 100, which is not difficult to find here, but more than 25 per year. But it's a lot more than that. It is all of the pre-operative, intraoperative, post-operative, ICU care, ER care, all the subspecialties all need to be present in order to take care of the patient that had a robotic operation. So we're very happy that we were able to get designated in 2019. And we just underwent, I think 2020, and we just underwent a 3-year reaccreditation. Northwest campus has undergone gotten accredited, and Valley Medical Center has also gotten accredited. So you may ask, why are you doing this? I mean, it's a lot of work. What do you get out of it? Well, whenever you place data in front of people, they become a little bit more honest. Everyone becomes a little bit more honest in front of data. This is the type of data that you can get from the institution, but we can get more relevant data if we were to implement the CHA agreement that we had agreed upon in 2020 that never got implemented because of COVID. But we will be working on trying to get that. And what it is that you can compare yourself to other institutions in terms of how you're doing. For this, you can see that it's just the instrument accessories, because without that agreement, you can't get patient care information. But highlighted in these colors are those areas where we're not doing as well. We're, for the most part, like Lake Wobegon, we're better than average. Everyone's better than average. But we're certainly not 10th percentile. And I think we have the expertise, we have the talent, we have the system to make it happen. And this will be cost saving for us. This will be much more effective for us. And in the long run, with this investment, it'll be less of a headache for us. But there's always some inertia to change. How do we get this data now with the MyIntuitive app? But even on other systems, there are going to be similar apps. And with this new system, the DV5 system, DaVinci 5 system, a lot of the data is king. So you're going to have a lot more data for cases, all the instruments that you've used for the last. This is all the instruments that I've used for the last 225 cases, XI cases that I've performed. And it quickly gives you an idea as to which instruments you should get off the pen, because you never use it. So those should not be processed each time. They should not exist on the pen and so forth. So these are financial decisions that we need to make. Like I said, we have 3 campuses that are now accredited for Center of Excellence designation in robotic surgery. That makes us eligible for Network of Excellence designation. We would be second to Sutter Hospital System. That's the hospital where the orthopedic surgeon used Robotic for the first time on a patient in 1992. So we're behind Sutter in Sacramento, but there is still yet the potential to become the second in the West Coast. But I am worried that Valley may not support us. We should also market strongly. The robotic instrument or platform used to be used as a marketing tool, and I admit freely that that is the case. Patients are now seeking robotic surgery over open surgery. They look you up. They ask whether you're doing robotic surgery and what the benefits of robotic surgery are. And you could obviously do the same for laparoscopic surgery, but they are actively engaged looking through your websites. And that's why I tell the residents and trainees, even if you think you'll never use it, please get trained. I thought I would never do surgery robotically after fellowship. I vowed that I would never do robotic surgery. And now 70% of my practice is robotic. So you just never know. Switching gears to acquisitions. These are the units that I've been involved in the acquisition since 2017 as chair of the Robotic Steering Committee. And you can see what units were existing at the time of the acquisition, how many cases we were doing on a quarterly basis for each system, and what system was installed that year. And you can see since 2020, we have not added a single unit. Just last year, we had 50 robotic surgeons accredited. I accredit all of them. I go through and sign that PDF file that I showed you. Now we have 71. So we've expanded more than 40% in a number of accredited surgeons, yet we have not added a single unit. I just don't know where this math happens. We have done surveys, and many of the surgeons here who are advocates of expanding the program have participated in the surveys. It was the best survey that I've seen, especially a surgical one, where more than 50% of the survey participants actually gave very meaningful feedback. And the main feedback is we have no access. And you may say, well, that's because you're a surgeon. You think you do more than you really think, and you think you have less time than anyone else. But really now we have, for the 3rd year, we have numbers to show that at a usual academic center doing complex cases, you're expected to have a system added by the time you're doing 60 to 70 cases per quarter. This takes into account what type of system you are. If you're doing prostates, or if you're doing, and I don't mean to belittle prostates, I just mean that if you have someone who is high functioning like Bill Ellis, who can crank through 3 prostates in a day with no trouble, he's on time every single time. He starts on time, he finishes on time. He's like the guy that I want to be, that I can't be. Then you're going to be doing many more cases. But if you're doing Whipples, you can't really do 2, at least for now. I'm not part of the 3-hour club. I hope to be soon, and I hope Dr. Sham will be too. But you can only do 1 case. So there are some limitations when you do complex cases in terms of how, and when you're limited on cases and you're also limited on ORs, then you end up doing non-robotic cases in robot rooms. And these robots are not that easy to move around. Regardless, you can see the number of cases that we're doing on average per quarter at both campuses. It's far exceeding the number that we need to be doing with these systems. These are how these units are financed. We've been pretty lucky, I would say. Most of our units have been capital purchases. No one buys robots these days. That's just ludicrous. You would invest that money in the stock market. It doesn't make sense on a technology that's going to become obsolete very soon, especially with the new system. We went on a trip to visit Intuitive at the end of March to look at the new system. We took 10 surgeons and some of the administrators. And on our way back, one of the surgeons from Valley said, "Oh, we're going to purchase one." And I was disappointed because we were hoping that we could all be part of an agreement, but also the fact that they were wanting to purchase. And they may be thinking, well, the time horizon for a platform is about 10 years. Here, I'll get to that. But if you look at this slide, you can see the time horizon for these units. The Da Vinci S was FDA approved 2000, went until 2009. The SI was SI was started in 2009. It was sundowned in 2020. XI started in 2014. You know, I was expecting it to get sundown in 2024, but then COVID hit. So we're expecting maybe 2027, but you can see already there's another system. And you may say, well, then just buy this new system and you'll be good for 10 years. And that's not the way that they know. And the strength of this platform now is data. So the data plan is going to be on a subscription plan. So it won't be updated unless you keep paying. So this is something that we need to figure out as an institution. But capital purchase basically is not the way that you should be thinking of it. This is how I thought about cars. You buy a car, it's cheaper than renting or leasing a car, and it's a lot cheaper than renting a car. So just buy a car and drive it into the ground. But robots are not cars. You can't think of it that way. And I think it took a long time to bring the finance folks to that realization. And a lot of my white hair is devoted to those discussions. Additionally, if you have a capital purchase, there's no technology obsolescence protection. If a new technology comes out, you're on your own. And that happened, as you can see on the right, for Northwest. There was a new generator that came out called the E100. And when a new technology comes out, people want it. There's just no way that you can stop them. And the only way to allow for that is by acquiring further. Okay, I'm going to move along a little bit and move on to the last component, which is the future. This is something called Case Insights. It's not fully developed. I know Andy Wright is working on it. I'm working on it as well. But it takes a lot of the performance indicators that are on the platform, and then you can use it to your advantage to train and keep up your skills. I'll just go to, yeah, so this is just a quick video. Sorry. Okay, that's okay. But it takes all the, maybe I can just show this slide. Yeah. So this is a urologic case, a prostatectomy, and the different components of the case. And it takes the kinematic information, what your hands were doing, and records all of it for the case. It segments the case into these different components of the case. And you can see the difference between an experienced surgeon and a novice. A novice is all over the place. The radius of interaction for an expert surgeon is 4 centimeters, or sorry, diameter is 4 centimeters. So what that means is that they're constantly clutching to roll their hands back into the field and operate with their hands very close to each other. And that's the most effective way to perform the operation. So this type of data is going to be available to you. It'll be just on your phone after you finish your case. You can go to that component of the case, you can review the case, and it will tell you what module you need to work on. And so you don't need Dr. Sham doesn't yell. You don't need me to yell at you to say, go do this module. Why didn't you do this module? Think, feel with your eyes or any of that. It'll just be there. And finally, the new system has what's called a hub system built in. It still exists already, but you have to purchase it separately. What it allows us to do is you can have someone brought in from outside. They could be on their phone or tablet. They can join in your case. They can see what you're seeing through the camera, and they can give you advice or, and that's built in. We at UW have this hub system that Dr. Sham developed. It's called the UW Hub, and it uses brand new technology called FaceTime and a very dedicated resident who's willing to put that phone up to the console, one of the consoles, and keep it there for hours at end. And he was doing a very difficult dissection yesterday in a redo bile duct resection that recurred at the anastomosis. Of course not, because it was a positive margin, but it was a node at the, just ugly, ugly case. Anyways, we tried to see how many surgeons we can get on this call. Dr. Atkinson was nearby, so we called her in for some advice. And Dr. McHarg, who I was on call with, was also nearby. So he was presenting his patient to me. And then my head just turned into a robotic pumpkin. But yeah, this is, while innovative, I think there are better ways to do this. And this is the final slide. But we talked about telesurgery. This is true telesurgery. This happened in February, I think. This is a new robot called Myra, I think, Myra. It has performed right hemicolectomies as an example. It only has 2 arms and a camera, but that's it, what that CEO is holding. So it went into space on SpaceX, 250 miles away. Surgeons from Earth were able to perform a surgical test, cut a rubber band, but they took turns doing that, 6 of them. But that's